Well, hello and welcome to the ICMDA webinar. Today, our topic is mental health and COVID-19 in low resource settings. I'm Dr. Peter Saunders. I'm the CEO of the International Christian Medical and Dental Association, which represents doctors and dentists in over 80 countries worldwide. And this is the sixth of our series of seminars on COVID-19. So it remains to me now to welcome Dr. Julian Eaton to our webinars today. We're delighted to have him. And Julian is Mental Health Director for CBM Global. He's Assistant Professor at the Centre for Global Mental Health at London School of Hygiene and Tropical Medicine. And he is a public health psychiatrist focused mainly in low and middle income countries. He leads a team at CBM, providing technical support for programs around the world, including in emergency settings. Julian was a member of the Lancet Commission on Global Mental Health and Sustainable Development, and he also contributes in an advisory capacity to many other initiatives, including the WHO's mental health work. He recently returned to London after 15 years living and working in West Africa, initially in Nigeria, and more recently in Togo. So, Dr. Eaton, we're delighted to have you, and I'll hand over to you now. Thank you.
Thank you for the invitation to contribute to this series of webinars. We are living in extraordinary times, and this is a time when well-being has really risen up the agenda. So I thank you all for participating and coming along to this, because mental health and well-being are really a cross-cutting issue that affect all of us, particularly those of us in the medical profession who are seeking to support people in a holistic way, whatever our specialty. So without further ado, I will start. My intention is to give a very brief overview of the key issues in global mental health, which is an emerging issue even in the context of development outside of an emergency, and then to talk broadly about emergencies and focus a bit more at the end, specifically on COVID. I'm aware that many of you are listening in a translated form, so I'm going to try to speak slowly as I do that. There'll be an opportunity for questions afterwards, and I'll be very happy to respond to them. So first of all, global mental health. This was an expression that didn't really exist 20 years ago, whereas public health at a global level had really focused a lot on communicable diseases and maternal and child care and others. Mental health really was not a priority in many countries. And it's only really in the last 20 years or so, after some important research that was done in the late 90s, that demonstrated how prevalent these conditions were and how disabling they were, that it's slowly risen up the agenda. And I've really noticed that during this COVID outbreak, there's been far more interest in mental health than I've ever seen before, even in the preceding outbreaks like Ebola and other emergencies. Some of the numbers that really surprised people and raised the agenda, as I said, are how many people are affected. So we know, for example, that broadly about 10 to 12% of all disability adjusted life years, so that's all burden of disease globally, is attributable to mental ill health. That's slightly higher in high income countries just because of the higher burden of other diseases in low income countries. But it's when you start talking about disability and the years that people live with disability that the numbers really shoot up. So much so that depression is actually the single biggest cause of disability in the world. And often that is comorbid with other health conditions as well. So almost a third of all the years lived with disability in the world are attributable to mental ill health. The great majority of these numbers are actually in low and middle income countries, but it's worth remembering that this is largely because that's where most of the people in the world live, not because there are far higher burdens in low income countries, although we will hear that in places where there's very high rates of poverty or ongoing conflict or other natural emergencies, that does increase the prevalence of mental ill health. But this is a truly global issue. One big surprise also in recent years has been when we've started to more accurately measure suicide, we've realized that it's actually the second highest cause of death in people under 30, or more accurately, between the ages of 15 and 30, of all causes of death. And this is a preventable cause of death that has not been sufficiently considered, and we need to really take it into account in our health planning and our investment, as well as in our clinical day-to-day work for all doctors, nurses, and other health professionals. Very importantly, there is a strong social gradient in mental ill health, as with many other parts of health, but we know that these problems disproportionately impact on people who have many other types of social disadvantage, with poverty probably being the most important, and unemployment, but also other areas that cause people generally to be less able to access support. They also tend to have more mental health problems. This was a quote in Mental Health, All Countries Are Developing, that was said by the previous director of mental health at the WHO, because in fact in all countries there is an underinvestment in mental health. Mental health services tend to be less developed than other types of health services, and people are less likely to be able to access care than if they have other types of health problems. In fact, in low-income countries, it's typically 85% or even more of people with severe mental illness who do not receive the care they should within the previous year. Within humanitarian emergencies, this is even more the case. Annually, around 200 million people are affected or displaced by natural disasters. And sadly, there are many, many ongoing conflicts around the world. This is not an issue that is going away. And in these situations, mental health is particularly at risk. The impact of natural disasters and conflicts is not only on human security, but also on people's physical health and their mental well-being. This is particularly the case for people who are displaced from home, either because of the physical effect of the emergency or the political ramifications of conflicts. And those people might be refugees across borders or internally displaced within countries. Looking forward, climate change is an enormous risk for mental health, partly because of the impact it has on refugees because of climate change, but also many other impacts of climate change are being seen now across different health conditions, which are often comorbid with mental ill health. The current global leadership is not working towards resolving many of the insecurity and the tendency towards conflict at the moment. So there's also a tendency towards more conflict, unfortunately, at the moment. So how are mental health and well-being affected by emergencies and by conflicts? First of all, we know that there's a substantial increase in prevalence of mental health and psychosocial problems during humanitarian emergencies. It's very important to stress that in the great majority of cases, we are not necessarily talking about diagnosable mental disorders like depression or anxiety or schizophrenia or bipolar disorder. We're mainly talking about populations who are distressed. That has a negative impact on their well-being. But it's very important that we don't overly medicalize that great proportion of the population who are distressed in this way. But it's obviously quite reasonable to think of this as an appropriate response to terrible situations. All of us would respond in this way. And in some cases, that's quite a protective mechanism. But a proportion of those people will go on to develop mental conditions that are diagnosable and that do helpfully enter into the realm of being able to be helped by medical and psychological professions. So the great majority of those will be what we would typically call common mental conditions, like depression and anxiety. And then there's a proportion of people who will have specific conditions related to trauma and the reaction to trauma. And that, as you will all know, is typically around the area of post-traumatic stress disorder. And there's recent research that came out of the WHO that showed that up to around 15% of people in conflict settings will have post-traumatic stress disorder. And that's much worse if people have been very directly involved, if they have been perpetually involved, so they have a continuing reinforcement of those kind of traumatic events and not able to have resolution coming into a safe and secure environment where they can find healing. Typically, the rates of all mental conditions broadly double during humanitarian emergencies and protracted conflicts. So those are people who have a new onset of a mental health problem as a consequence of such an emergency. But of course, there are already people who have existing mental health problems. And those people are also typically worse affected by such a traumatic environment to be living in. And there's a special group of people who I'm going to come to later when we talk about COVID. But that's people who are living in institutions. I'm thinking particularly about people who live in psychiatric institutions or care homes. But there are also other institutions like children's homes, places where people with disabilities are often looked after in many countries, and prisons. And those people can be particularly badly affected. So we always need to keep an eye out for people who already have a tendency towards a mental health problem or have a diagnosable ongoing mental health problem, who are likely to need particular support at this time, just at the time when the normal support they rely on often falls away. So how is it that there is this increase in mental health problems at times of emergencies? First of all, there's the distress associated with experiencing trauma and experiencing loss, particularly loss of loved ones. So, as I said, this is particularly the case when the problems don't go away, when people start having their usual resilience and coping mechanisms surpassed. They can't cope with the extent of the trauma and it going on for too long. Secondly, at this time, the usual supports that people rely on tend to not be so good. That's either the formal supports of health systems and services and professionals supporting them, but also their families who are themselves distressed in extremis or having lost themselves relatives are unable to provide the usual social support they provide. And that's also the case, of course, for extended informal networks like churches, like civil society networks and other informal supports that people usually rely on. Health and care systems particularly often break down. Of course, the people who work within those systems are people themselves. They themselves might be unable to travel. They themselves might be ill in the case of, example, a pandemic outbreak like we have now. And the physical infrastructure that they rely on might break down, including medication. I mention medication specifically because many severe mental conditions like bipolar disorder or schizophrenia or neurological conditions like epilepsy require ongoing access to medication for people to remain well. And of course, that's true for other chronic conditions as well. It's worth remembering that sometimes these emergencies have a very long lasting effect and people are not so able to recover if, for example, they lose their job or these systems break down in a more long-term way. So people will need more support to recover after an emergency and those systems might not quickly pick up again. We'll be thinking about that in a minute when we think about the likely long-term effect of COVID on the global economy, for example. So what evidence is there as public health practitioners in thinking about how we can support people? Well, there is a lot of evidence now. There are a lot of good global guidelines and global standards that can help us to build a good response, for example, during COVID and other emergencies. First of all, the strongest evidence is recognizing that it's not us, it's not health professionals, even mental health professionals, who are going to make the biggest difference in people's lives. It's the networks, the families, and the communities around people that need to be strong enough to provide for them during times of need. The most basic needs that we have of shelter, of food, of water, to be safe, those are the key things that need to be put in place first. And that is a very key part of the guidance that's given, that we need to first focus on getting basic needs up and running. We need to strengthen and make sure we make use of the traditional supports on which people rely. That is often churches, other religious institutions, families and networks which might be broken apart during times like this. And there are important lessons I think we've learned during COVID about the absolutely central importance of social support. And actually where our reaction to COVID in isolating people and keeping them apart from each other has had a specifically negative impact on mental health. And the ways that modern technology has actually been an important way that we've been able to try to overcome that separation and isolation that we've seen. So communicating and reuniting people is very, very important. And that's, of course, particularly important for children who, if they're orphaned, for example, or even if they're just separated from loved ones and parents, need to quickly be reunited with them. There's good evidence that children particularly need regular structure in their lives. And so when schools stop working during emergencies, it's very important to set up an infrastructure where children can find a space that is safe for them to be able to be children again, to play, to interact with other children, and to be safe in an emergency situation. It's very important to recognize also that particularly vulnerable people often are at particular risk during times of emergency, and we need to think about putting in place protection measures to make sure that they're able to remain safe at that time. We tend to think, first of all, when we think about mental health, of mental health professionals providing support. But actually, for people who need more mental health support than they can get from that environment around them, their family and their community, it's primary care. It's the first line workers who are the first people to be able to provide helpful mental health support for people. During the Ebola crisis, it was often burial teams who were engaging with people first. It's often nurses or dentists or teachers or social workers who engage with people the most and certainly the earliest during emergencies. And there's a very important resource that's available called psychological first aid, which helps people in a very brief 1 to 2 day training to be able to provide good quality empathic support to people to make them feel better in the immediate aftermath of an emergency. So the acronym before you is mental health and psychosocial support. Always thinking at the same time about mental health in a very broad sense of addressing well-being and distress, as well as symptoms of mental disorder that we often talk about. The Interagency Standing Committee is the global body that provides guidelines for supporting people during emergencies, and the Mental Health and Psychosocial Support Reference Group, of which I'm a member, has provided very good guidelines for how to support people, both in general emergencies and more recently during COVID. The founding principle of that is that we need to first think about basic services, security, as I mentioned, moving up a pyramid where there will be fewer and fewer people who need it, getting help from community and family support, then frontline workers in general, before people get to specialized care for a few people who need it. Just to very briefly mention that in this journey of global mental health becoming a more recognized part of public health and development, emergencies have often been a time where people have recognized the importance of mental health. And after that, we've been able to build stronger systems than were available before the emergency happened. I want to give a brief example of that in relation to the Ebola crisis in West Africa. I was living and working in West Africa at the time and responsible for CBM's response in Sierra Leone. And afterwards, I was asked to go and do a review for the World Health Organization of how well the mental health and psychosocial support response was done in Sierra Leone. There's a couple of key points. First of all, the investments we had made in health system strengthening in general, and particularly in mental health system strengthening, were crucial for there to be something in place for when an emergency happened. By the time an emergency happens, it's often too late to set up complex systems. You need to invest in advance to get these things up and running. And we're finding that now with COVID as well. It was also important to make sure that mental health was seen as a part of the broader emergency response program. So that was something that historically would have focused entirely on building emergency hospitals, on surgery for trauma victims, and actually integrating mental health properly in that planning, again in advance ideally, makes a big difference to the quality of care people can receive during an emergency. There's a summary on this slide of the particular lessons we learned during that emergency, but because of time, I'm not going to go through that in great detail, but these slides will be available for people who want to have a look at them afterwards. I wanted to talk briefly to this audience, of course, particularly about the way that we think about faith within the context of mental health and development in more broadly. First of all, it's worth recognizing, as I'm sure many of you will, that particularly in low-income countries, but also in high-income countries, most people in the world have a spiritual worldview. They don't isolate their faith and spirituality from their day-to-day lives or their health or their mental health for that matter. So when we think about mental health, people often already consider their spirituality to be an element of their mental health. And I think by artificially separating that, we don't do anyone any favors. And people find it much more enriching and supportive for there to be an element of spirituality within the thinking around their broader mental health. The consequence of that in many countries is that people will not naturally go to mental health services or a general doctor, a primary care doctor. They will go to their traditional healer first. And the work we often have to do in my work of working in strengthening mental health services in countries is to engage with those other systems of healing, the traditional healers and the pastors, churches, the mosques, imams, to work collaboratively with them to make sure that we're able to provide good quality care for people who seek their support in times of distress. In some cases, what people get when they go to their spiritual leader or the church or a healer of some sort is good. They find that they get good guidance and they find that they get good support during that time of need and distress. Unfortunately, often they also experience judgment, exclusion, and sometimes even pretty brutal abuse, especially people with severe mental illnesses where their behavior is very disturbed. Often the support they get actually is much more about controlling them for the community and society and the families to feel safe, rather than actually healing them and building them up to be able to live a productive life in the community. And the way that they are treated largely depends on the theological perspective or the beliefs that religious leaders have. And we therefore have an important role in the church to provide good guidance for how people can get support in their church or through their religious leaders. There is much common ground between modern approaches to mental health and psychiatry and the way that many religious traditions, including the Christian tradition, think about mental health, thinking broadly about a biological and psychological and social and spiritual approach to a whole person. And I think it's important to acknowledge the role that the International Christian Medical and Dental Association and many other Christian organizations have had in promoting a holistic perspective to health. So very briefly, what can the church do to promote mental health and well-being and development? First of all, I think it's really important to have the conversation, to bring church leaders together to think about mental health and how they can respond to the mental health needs of their congregations. Many already do a very good job of this and see it as an important part of their vocation. But we do need to bring this into the light, as in many countries it's still not talked about. We need to make sure that those leaders are supported by the national church body and encouraged to do a good job of this work. Sometimes it demands real examination of theological principles. For example, until very recently, suicide was illegal in many countries because it's perceived as a sin. And that really needs to change so that we can have people feeling included and supported during difficult times, not excluded. And then, of course, the church plays a very important role in providing practical care and support through their health services, social services, youth groups, women's groups, and others. And it's important that we think about practical means, programs, work that those organizations can do to support people. So let's think briefly and specifically about the COVID-19 outbreak. How does it affect people? Well, firstly, it's worth remembering the distress that it causes people itself, because it is a contagious disease that makes people feel worried and anxious, and they may lose people who die from the condition. So that's a very natural reaction to feel anxious and worried about this disease that is so unpredictable at the moment, and we know so little about it, and we hear so many scary things on the news. Some people will go on to go beyond distress and their coping mechanisms to develop mental conditions. And we also need to find ways of mobilizing the health system and mental health system to support them. The other thing that has been very key during a pandemic has been the way that people behave in terms of their risk of transmitting disease, for example. And there is good evidence coming out now that people who have diagnoses of depression or anxiety behave very differently to other people. For example, they might not take such good care of themselves, and it's possible that they are less likely to properly comply with advice around social distancing, for example. But it's not only the effect of the condition itself on people that is causing damage. We're increasingly seeing the negative impact of the responses that we have brought about to the condition, to the pandemic. For example, isolating people, quarantining people. That itself is a source of distress, not being able to get support from people around them. Being stuck in a contained environment where you can't get out and see other people is also particularly distressing for people in very small, crowded environments, small houses in crowded environments, maybe where there's children around who are bored and frustrated. Many of us have experienced that ourselves. And one of the very sad things that we've been hearing about more and more is people who actually live in violent households, children and women in particular, who are unable to get out and to seek support in a way that they usually would. There are also the economic impacts of losing your job or worrying about being able to get hold of food and other essential items. And this is particularly crucial for the many, many millions of people in the world who are on subsistence income, who rely on going out to trade every day to eat that day, and being told by your government you can't go out has very profound ramifications on not only your physical well-being, but your mental well-being as well. And then to think in the slightly longer term, if we see a massive global recession, that is going to push many more people into economic problems, into poverty, and we're going to see a substantial reversal of many of the gains of recent decades towards the Sustainable Development Goals. And this is likely to affect the most socially excluded, sadly. So what can we do to support people and to enable a good public health response during COVID? Well, the first thing is that we should be promoting more communication. I don't like to talk about social distancing. We should be talking about physical distancing and social connectivity through other means. So to reduce social isolation, make sure, particularly that people who are isolated are able to access basic essential needs, and the support of the church is very essential in doing that. We need to have clear and honest public health messaging. Unfortunately, there are many examples where populations do not trust their governments because they haven't been honest in the past, or even honest during public health emergencies, and that tends to lead to distrust and people not feeling safe, secure, and not following public health messaging. A practical way of making sure that works better is to engage with leaders, including church leaders, to be the conduit of messages to populations. So helping people to be hearing messages from people they trust. We need to make sure that we leave no one behind, that particularly vulnerable groups are not forgotten, which is often the case. Even in Spain, very sadly recently, we heard about some deaths in a care home, not because people got COVID, but because the staff did not provide adequate support for them and they died. And that is happening in institutions around the world, sadly, including institutions for people with mental health problems. So people with chronic illnesses, people with disabilities, older people, all need to have specific and proactive support given to them. And then many of us, healthcare staff, are in particularly vulnerable situations, both to physically contract the condition if we're going to do our jobs well, and also to have more mental health problems as we worry about ourselves, our own health, and the effect we might have on our families from being exposed to the virus. And then finally, we need to think about stigma. That stigma has already raised its head in relation to COVID, where people often who are already excluded from society are given additional burden of blame for the condition. And that's happened to African people in China. It's happened to Chinese people everywhere in the world. It's happened to Muslim people in India. And we need to really fight against that. It's based on ignorance, of course, and we need to stand up for people who are being additionally stigmatized by this problem. In many cases, that's also happening, sadly, to healthcare workers who have been attacked in a number of countries, and we need to stand up against that. Just very briefly, the core messages that we need to give out in the kind of public health announcements that are going out that specifically relate to mental health and how people can look after their own mental health. First of all, it's good to follow the physical health advice that's going out about avoiding infection. But we need to be careful not to overwhelm ourselves with these messages, because that can increase anxiety. So don't watch the news every hour of every day, listen to every conspiracy theory, but be careful to listen to good quality advice and spend the rest of the time thinking about ordinary things and not completely consuming yourself with COVID. Maintaining a healthy lifestyle, eating well, sleeping well, exercising properly are very important for your mental health. And avoid negative coping mechanisms like drinking more. We know that many countries alcohol use has increased, and people are smoking more also in some cases. It's good to take time out to get away from a stressful situation if that's possible, and to talk to people, to talk to trusted friends, colleagues, and if possible, to a counsellor if you feel you need that. And in some countries, helplines are available, they're not everywhere. But the church is able to provide that kind of support in many cases. Looking after yourself is very important. And I want to share particularly this resource, which the WHO has recently released and is on the link I'll be sharing later, about how you care for yourself. And a lot of that is around trying to reduce the causes of stress that I talked about earlier, engaging with people. Sometimes there are some specific exercises around breathing. But I think most interestingly in this particular resource I want to mention is the idea of coming back to your values. What's important for you in life? And how can you make sure that you express that even during this time? Find time to go back to what's important for you. And that's caring for other people, caring for your family, and standing up for what's right, even during this difficult time. And many people have talked about how the best in society has come out during this emergency as well. So here are some resources that you might want to look up. First of all, the Mental Health Innovation Network at London School of Hygiene, where I work, has a collection of all the good mental health and COVID-related resources available. And CBM has produced this hands-on tool, which is available as an app, also via this link here, for very practical ways that you can support particularly people with disabilities and people with mental health problems in your community. I just wanted to end with a final thought about after COVID. This is a picture of the beach at River Number 2, just outside of Freetown in Sierra Leone, a country that's had many crises, including the Ebola crisis I mentioned already. But people and their societies aren't defined by crisis. And as COVID plays out, and as we think about a world after COVID, we need to be thinking about how we can bring together the best of who we are as a church, as communities, and as a world that looks after each other, to make sure that we build on what we've experienced during this time and don't let it define us as it often feels overwhelming during these particularly difficult times. Thank you, Peter. That's all I have to say.
Thank you very much, Julian. Wow, there's a huge amount there that you managed to pack into a very short time, and it's already generating some questions. So perhaps we could start off, Julian, first of all, and this is perhaps a question that you might have expected quite early on, and it's about the principles around sharing the gospel in the midst of crisis to people who might be traumatized or who are suffering loss, or perhaps even finding that their worldview is not inadequate to bolster them and offer the proper support. Could you give some pointers here for people, things to avoid and opportunities to take?
Sure. I think the first thing to point out is that we have already a community of people who are Christians who are going to be very negatively affected by this. And I think it's the church's responsibility to provide a space within that family where they can find support, as I mentioned earlier. I think for people who are outside of the church, of course, it's a time of distress. It's a time where they might be seeking answers. And I think certainly the way that I have lived my life, the way that I think CBM as a Christian organization working in a development context sees this. It's in our actions that we will be able to express our Christian faith. Clearly, it's a time where people might be seeking such answers. And I think it can provide an opportunity to talk to people about faith. I do worry about people who, in times of distress, might be vulnerable, and we need to be very careful about how we do that, and do that very sensitively. But I do think, as I said, that spirituality and thinking about faith is a part of people's lives, and they recognize that particularly is a part of their lives, sometimes at times of distress. And it's not unreasonable to be thinking about that with them. But we need to do that in a very sensitive and thoughtful way.
Thanks very much. Paradoxically, the whole coronavirus crisis has created some opportunities as well for this person asking the question says, for example, anorexic patients can practice eating in public. Patients who struggle with social anxiety can try to engage in online activities and so on. Would you like to perhaps make some comments about some of the positive things and opportunities that we can see coming out of this crisis, so we don't waste the crisis?
I'm really pleased that that was raised, because in the very broad community of people with mental health problems and psychosocial disabilities, there's certainly a diversity of experience. I think the most obvious that we think about and we hear about is people who are finding it more difficult, are more distressed by what's happening, because we all are. It's more challenging for all of us. I've also heard of a number of people who said they don't have to go out anymore, which is a great relief. They don't have to meet people face to face, which is a great relief, and they're able to communicate online, which they find much easier. So yes, it's certainly been a time where some people are finding that they're able to get some relief from the normal stresses of life just because of the unusual situation. I think on a broader scale, one thing that many people have found really helpful is that normally they feel like they're the only ones who are anxious and worried and finding it difficult. No one else understands how they feel. And suddenly we have a whole community of people who are having to worry about their day-to-day life, their family, all the things that causes some people to really struggle on a day-to-day basis. So suddenly mental health is something that everyone's talking about. And many people have found that really helpful and encouraging, actually, to be able to find people around them who are willing and interested in talking about their well-being, and even from a position of vulnerability, and not from a position of them and us, but actually we're all in this together. I don't know about other countries, but certainly in my immediate environment and in the country as a whole, in the UK where I live, there's been a lot of conversation about how this has brought people together. Whereas, we live in generally quite a segregated society. There are the haves and have-nots and the rich and the poor, and suddenly we all have something in common, and there is a sense of solidarity that I think people talk about often. It was like that during the war, that there is a kind of sense of everyone being together. And I think many people have talked about what's happening at the moment, bringing out some very positive things about the community that they want to see happening in the longer term, that they've actually met and engaged with neighbours in a way that they haven't, even when they physically could do so much more easily. And we need to try to find a way of making sure we don't lose that, and we build on that in the longer term.
What specific roles can churches play in mitigating the impact of mental health problems? You've already touched on this in your talk, but what would you like to emphasize here?
I think I would really emphasize the role that the church should be playing and should carry on playing afterwards. I suppose this follows on from the previous question, really. Now is a time of particular need where people seek support from the people they trust, and that's often church leaders, and it's often church elders, and it's often brothers and sisters in that faith community. And I think if we are able to provide good response, loving care, prayerful support when it's sought, finding innovative ways of reaching out to people and supporting them in their physical needs as well during this time, then I think that really will be a good way of demonstrating that we are a community together. And that should continue in the long term. I would raise particularly what I said about the good and the bad, that the church has, I think, always been a place where people do find that support. But it's also a place that's been very judgmental of people, particularly with severe mental illnesses, who are excluded from society, who in many countries where the people on this webinar work are homeless. They wander the streets. And that is something that the church should feel very responsible for responding to. And I think if we are able to do a good job during these difficult times of looking after members, of looking after the extended community during times when they're seeking support, then we should also be thinking after this crisis, how can we make sure that people with severe mental conditions, who in many countries are chained up in houses, are sometimes chained up in churches and prayer camps, how can we do a better job of the, I would say, generally poor way that we have responded to those people in pretty extreme need? And we can do a better job of that, I think, in the long term.
Now, you said earlier in your talk that the home is not necessarily a safe place for people to be during lockdown. What advice could you give to victims or potential victims of domestic violence who are stuck somewhere not safe?
It's extremely difficult to imagine how difficult it must be to be in a home where you have no capacity to escape, to find a place where you can talk to people, to communicate that you are at risk. So I don't think I'm very well qualified to directly advise those people. I think what the advice from professional organizations working in this area is to find a way of communicating if you can. And in some cases, there are some structures to do that. And obviously the police is one option in some countries. There are helplines in some countries. There are organizations specifically set up to help women who are living in violent homes, for example. So those have experienced increase in demand for their services. We know that school is often a safe place for children for those hours of the day, or to have teachers who can see that there's something wrong and refer them appropriately. And that obviously is a way that's broken down now. So I think the main advice for people is to try to communicate your need for safety, and that you should not put up with violence at home. But that's an easy thing for me to say and a very difficult thing to do in practice. I think what's easier to think about is what we as responsible organizations can do to help people in those situations. And for the purpose of this webinar, I think churches and church leaders in particular are often people who have very good insight into what's happening in people's lives. And it's an opportunity, I think, to step back and think, this person, and it's often a woman or a child, who has been telling me for all this time that they are being abused at home or are not safe at home, I need to reach out and find out what's happening to them, because it's not likely to have gone away. And I think that's the most important thing, that we mobilize the networks we have, either as church leaders or as health professionals, to say, let me not forget those people whose silence doesn't mean the problem's gone away. Their silence means they're probably in a more difficult situation, and to proactively seek to support them at this time.
Julian, can you point us to any specific resources or training for churches or for pastors that's available?
There was one resource that I put up on a slide, which I hope people will be able to access afterwards. I think they will. This will be on YouTube afterwards and on the ICMDA website. That is more broadly about the role of faith communities in emergencies, and that's a very good resource. It was written by the Lutheran Church Global and Islamic Relief. There are also a number of resources available from national churches who increasingly have mental health resources available, sometimes quite theological for preaching, and sometimes very practical for things that churches can do for mental health. So at a national level, I can't particularly help you. CBM has a lot of resources, not specifically around faith, but that are very practically developed for organizations working in health and development in countries, and often those are church-based organizations. So there are a number of resources available, but I think in many cases the very practical resources available that I mentioned on the Mental Health Innovation Network are also very helpful for churches who are doing community work. Peter, you might be better placed than me to link people to good health resources that are specifically Christian in nature and seeking to support people from a health and Christian perspective.
There are certainly some good resources on the ICMDA website on our coronavirus pages, which you can find very easily. Can you give us some tips for frontline healthcare workers who might be psychologically distressed during this pandemic, who are really feeling it? Perhaps some basic do's and don'ts to help us.
I think one of the things that defines us, those people who enter into healthcare professions, is a desire to support people. And we often don't get the balance right when there are many demands on us. When we see many people who are distressed and people queuing up outside our clinic, we don't tend to look after ourselves. So I think the first message really is to acknowledge and recognize your own mental health and well-being. Notice if you're up at night worrying, not going to sleep easily, eating unhealthily, or not bothering to eat at all because you're so busy. How are you treating your husband or your wife? Are you irritable with your children? Those kinds of things. But often the bigger cause can mean that we don't think about ourselves. And of course, it's a truism to say that we can only help other people if we are well ourselves. But I think that is incredibly important at this time in particular. I know many colleagues who have felt very worried and anxious about their families. And I do think that we have a particular responsibility to care for those around us as well, because they are our very natural support for difficult times. And that has a very real impact during times of infectious disease. I know during the Ebola crisis, many healthcare workers did not live at home for a year because they did not want to take the risk of infection home. That's very difficult. But I think the first thing is to look after your own mental health. There are some very practical do's and don'ts. I think the link between physical and mental health care and our spiritual well-being are very important, that we shouldn't neglect our eating and exercise and sleep and all of those things. If we have been used to fellowshipping regularly within a church group or within another group, we should continue to do that and not to neglect that. We need it even more, if anything, at this time. And I think seeking support of other people who are in a similar situation to us. So often it's other healthcare workers or other people in a similar situation to us who have the most capacity to understand where we are, and maintaining good networks and links with people, including Christian medical associations, can be a very helpful way of speaking to people who we don't have to explain everything to, which is often the case for other people. But we can get a lot of support from people who are in a similar situation to us.
Thanks. We've probably just got time for one more question. And you've touched on this a bit. I think people may have been surprised just to hear how incredibly common mental health problems are, particularly in these sorts of emergency and crisis situations. But it's understandable that Christian healthcare workers in the emergency room or on the front line are often overwhelmed just with the task of managing the physical symptoms and the emergency aspects of it, and may have very little bandwidth left for being on the lookout for red flags of mental health disorders. Could you just share a little bit about your experience in advocating for psychological first aid, mental health screening tools on the front lines and any practical steps that people could use.
But I think one of the things you said, I'd just like to pick you up on. You said that people are so busy doing physical health care, they feel they haven't got time to do the mental health bits. I recognize that feeling. I absolutely can see where that's coming from. We've got forms to fill in and blood tests to do and examinations to do. But of course, we know that these things are very closely interactive. So if you have a person, let's say, with a chronic condition like diabetes who's depressed, they're far less likely to be compliant with the recommendations you give them than if they are not depressed. So actually thinking about people in the whole and acknowledging the emotional component of a whole person's experience at that time makes it likely that all your physical efforts will be more successful. That's an important thing to recognize. It doesn't take longer to be empathic in the way you engage with people. That's the other thing. And the core components of psychological first aid is not to add a 12-session psychological intervention. It's your immediate engagement with someone. It's about listening thoughtfully, acknowledging someone's emotional distress as a part of what they're saying to you, rather than screening that out and only answering the bit of their question that's about a physical thing that you feel confident to talk to. I think the anxiety is that if you start acknowledging these emotional aspects of what someone is saying, then it will just explode into a lot of issues that you can't respond to. That is a risk, of course, but I think what you need to do in preparation for that is think about where people can be helped to go to provide that support, that you're not the person to give, but to acknowledge it as important and help people to reach that place. Psychological first aid was designed really for emergency settings, to be taught to people in 1 or 2 days so that they are able to be empathic, to ask some sensitive and thoughtful questions and to listen carefully, and then advise people sensibly about immediate things like sleep and all of those kinds of things, but also to help them to go and get the support they need from elsewhere. So it shouldn't add a great burden to a doctor trying to do a good job of thinking about someone's well-being as well. But I would say that it could very well help that person to leave your consulting room feeling like their physical health has been helped, of course, but also that you're a doctor who's thinking about them as a person, not as a piece of meat, which is often what people can feel. So these resources specifically, psychological first aid is probably the one I would advocate, because there is risk of harm in doing the wrong thing in mental health as well. And it's simple and practical, is based on a lot of field experience, is available at the WHO website and many organizations during emergencies. It's probably the most common thing that psychosocial intervention organizations will teach and train. If you have staff within your clinic or within your hospital who are regularly meeting people who are distressed, then organizing a psychological first aid training is a very good way of quickly getting 20, 30, 50 people able to be much more thoughtful responders to distress by giving them some basic skills. And of course, many of us who work in health do it because we want to be supporting people. And it's much more satisfying if you know what to do when someone starts crying, or when someone tells you they're thinking about suicide, or they're really worried about something. It's much nicer to know what to do about that, rather than just to worry about it and put them off. So I would encourage people to look into that first basic responder skill set that I think can help us have a much more satisfying relationship with our patients.
Julian, thank you so much. I'm afraid that that's all we've got time for today, although the questions are still flowing and flowing. Thank you very much, all of you, for coming to this webinar. So it just remains for me to thank again Dr. Julian Eaton for this fantastic presentation, all the questions you've answered and raised as well, and for our translators, Augustine, Daniel, and Miralee, for your excellent work. So do join us again on ICMDA webinars coming up. Lots of information on the website, see our YouTube channel, and of course, as I mentioned, follow the links in the letter that we'll send you and tell others about the resource as well. God bless you all. Thank you.